All right. Well, tonight let me just say this. Well, welcome to our class of Conversations in Health, Global to Local. And while this is a class on short notice, you all are very lucky. We have a spectacular guest with us tonight. Um, as you know, we typically are prepared ahead of time, but because it's short notice, I'm going to give you a little bit more bio than I typically do on a given night of our guest lecture. But Professor Gyapong, who's with us here, is currently a visiting professor here at Georgetown University. He is in the Global Health Program in the Graduate School of Arts and Sciences, but he has had a long and distinguished career in academic and public service. He is the immediate past Vice Chancellor of the University of Health and Allied Sciences in Ghana. Before that, he was the Vice Chancellor for Research, Innovation, and Development at the University of Ghana. And he's also had a career in public life. He was the Director of Research and Development of Ghana Health Services for 12 years. He was also studied in Ghana and get his basic education there. He also got his PhD in epidemiology from the London School of Economics. He's actually also practiced as a physician in a rural community in Ghana. His research covers, let me just say, he has more than 150 peer-reviewed publications. He's edited numerous books, but his area of research has been primarily around infectious disease epidemiology, especially lymphatic filariasis, and other neglected tropical diseases. So we are really lucky to have him both in our Georgetown community for this year, hopefully, as long as we can keep you.
Sure.
He has also been a longtime friend of Georgetown University. Our students have been going to the University of Ghana for many years, and we're thankful for your support. But anyway, I think we have a terrific evening ahead of us. So the other thing I thought I would do, maybe just to give you a sense of the room, is I would ask everybody here to introduce themselves and what program they're in. Mm-hmm. Everyone here is an undergraduate, and so everyone here is thinking about what to do in their lives. Yeah. So for people like you and me, it was a long time ago. But Shreya, and I know you know Professor Gyapong. Why don't you start us off?
Hi guys, my name is Shreya. I'm a junior in the School of Health, majoring in global health, and I'm from the San Francisco Bay Area.
Great. Abby?
Hi, I'm Abby. I'm a sophomore in school nursing, studying nursing.
Mm-hmm. Where are you from?
I'm from New York.
New York.
I'm Gia from Minnesota, and I'm a senior in the SFS, majoring in international affairs and global health.
Mm-hmm. Hi, I'm Sylvie. I'm from Portland, Oregon, and I'm a freshman in the School of Health studying global health.
Hi, I'm Maddie. I'm a sophomore. In the School of Health studying global health in Boston.
Hi, I'm Ben. I'm a sophomore in college studying gov, and I'm from Chicago.
So the college is our college, liberal arts college, and College of Arts and Sciences, and gov is the government, political science.
Sure.
Hi, I'm Ryan. I'm from just outside of Chicago, and I'm a freshman in college studying biology.
Mm-hmm.
I'm Colin. I'm also a freshman in college studying biology, and I am from outside of Seattle.
Mm-hmm.
Hi, I'm Madeline. I'm a freshman in the School of Health studying science, and I'm from Chicago.
Hi, I'm Lily. I'm a freshman in the School of Health studying global health, and I'm from Arlington, Michigan.
And so despite the fact I'm from Chicago, I had nothing to do with the fact that we have such a large percentage of Chicagoans here. Yeah. But anyway, thank you. And so, as John, as I told you, one of the things we like to do, so our basic pattern is we spend the first half of the class with you and we have a little bit of a conversation about your life, and then open it up to the students. And we'll go for about an hour or so, and we always have a rich conversation here.
Sure.
So I'm gonna ask you to start at the beginning.
Well,
I'm gonna ask you to give us a little sense about where you grew up and what attracted you to medicine, because you went straight to studying medicine and practice, and kind of give us a little bit of a picture of where it all started. And you have a sense of where we're all coming from, but it would be great to get a sense of where you were coming from.
Good. Yeah. So good to be here. I'm John. Most people call me Johnny. So I'm from Ghana, as you've already heard. I'm from a part of Ghana called the Eastern Region. It's not the most eastern part, but it is called the Eastern Region. And I grew up in a typical village in Africa where basic amenities didn't exist. And my father joined the military, and he took me to the city, and I had opportunity to get access to education in the city. And by God's grace, I was able to excel in the opportunities that came my way. And I ended up in medical school. In Ghana, from senior high school, for some reason, you're expected to know what you want to do. So, so you get into college or university, deciding to do engineering, medicine, business, or any program. So it's expected that by the time you do we did the A-level. By the time you do your A-level exams, you're expected to make a decision as to where you want to go. But I was influenced by my father. My father was a nurse in the military, and I guess he guided me in that direction. And subconsciously, I decided to get in there. We unfortunately, I say unfortunately, because we have a system which tend to pigeonhole people in certain areas, as opposed to what you have here, where you can come in here and do a program in biology and decide to go and do medicine or decide to go and do something else later on. For us, you are in or out, and it's not the best. I think we need to try and revise that system. But having said that, that is where I found myself. I found myself in medical school, and I managed to get through medical school, not easily, but somehow we got through. And during 5th year in medical school, we do what we call a rural posting, where you are embedded within a rural district hospital for close to 3 months, where you do a community health project. And that was when I got really, really exposed to the real challenges of health in the country. Challenges with malnutrition, challenges with malaria, and many infectious diseases, maternal and child health issues. I mean, they hit you in the face. Sometimes you go to the district hospital, where basically following the physicians, and we're basically apprentices in the trade. And I mean, you see the children on the children's wards. It's so pathetic. Occasionally there'll be an outbreak of measles, and it was bad. So it took my mind to the fact that, look, hey, yes, it is good to offer the best of clinical care, but I think that we need to nip the problem in the bud before it gets into the hospital. And for that reason, I had an inclination to major in public health. So I was torn between specializing in obstetrics and gynae, pediatrics, or public health. Sometimes we want to do everything, but in life we can't do everything. So I was, after medical school, I worked in Kumasi, which is the second city in Ghana, for 2 years, and I decided to take a posting to the rural district. That was when I really got exposed. You work your hours out. I mean, you could be on call around the clock, and it gives you a lot of experience, and you really, as the epidemiologists would say, that is where the rubber actually meets the road. You'll see the real challenges of life, and having to work in hospitals with very limited infrastructure was challenging, but at the end of the day satisfying when you see the results of the outcome of your interventions. You feel some sense of satisfaction. So I decided to pursue a public health career. So I did a master's in public health at the London School of Hygiene and Tropical Medicine, and then go back to Ghana, got engaged in a lot more research, because at this time I'd become very interested in the neglected tropical diseases, lymphatic filariasis, which presents with very big legs, and then onchocerciasis, which presents with blindness, and many other skin diseases. As I worked in rural Ghana, in the northern sector, these issues came to the fore. So I went to London for a year, did my master's, came back. I had a project that was funded by WHO, TDR. TDR is a Tropical Disease Research Program of the World Health Organization. I got a small grant, and I did a pretty good job, so I got a bigger grant, and then another grant. I started from $5,000. My first grant was $5,000. My last grant from WHO TDR was close to $10 million. So you need to, I mean, that is one point.
That's quite a multiplier.
Yeah. So it's incremental. You have to do a good job and let them build. You build confidence in yourself, and then the community would also build confidence in you. Of course, the $10 million was for a clinical trial on rectal artesunate, which is used for severe malaria. One of the artemisinin-based compounds which you use to treat children with very severe malaria. Yeah. Of course, clinical trials cost a lot more money than regular field epidemiological studies. But the point I'm making is that you have to start small, and then you graduate up there. Yeah. So through that, you meet many people. I met Bernard probably 25 years ago. In one of the meetings, you make a presentation here and there, you make friends, and then you keep the old friends and keep going. So after doing quite a bit of that, I went back to London to do a PhD in epidemiology. And I guess after doing that, my market value also went up. So I moved into many other consulting work. Eventually, I became the director for research and development within the Ghana Health Service. And after a while, I'd had enough of the Ghana Health Service. So I decided to move into full-time academia. So I joined the University of Ghana. I became the vice dean for the School of Public Health. Then within a very short while, I became the pro-vice chancellor for research, innovation, and development. So here you would say the vice president for innovation, research, and development in your system here. Yeah. So I did that for 5 years, and then an opportunity for the vice chancellor or the president of the university, a new university came up. And that university was focused on health and allied sciences. So I was very competitive, and I got the job. I did it for 6 years. And after that, I turned 60 years. Maybe I may not look it, but I'm 60 years old. And in Ghana, when you hit 60, that is supposed to be the official retiring age. Of course, you can still continue to work in the university, but you cannot hold office in that system. So after that, I decided to take a sabbatical leave, and here I am.
We are thrilled to have you.
Yeah.
This is terrific.
Yeah.
Well, let me ask a couple, maybe focus on a couple of the pivot points.
Sure.
I'm really intrigued about, I guess the first question would be just the pivot you took when you were the director of research for the Ghana Health Services, which is the public sector health
Sure.
system,
Yep.
to academia. Was that just time for a change, or how did you think about the sort of more research-oriented academic career versus applied research? I gather if you're, my sense was you were doing much more applied
Yes.
research and analysis in the
Yep.
system.
Yeah. So I was doing applied research. First of all, because I was employed within the Ministry of Health, the Ministry of Health had decided to set up research centers to inform its policy and programs. I found myself in a good place where I had opportunity to do research on many issues, implementation research from why vaccines are not being taken to national health insurance to maternal and child health. I mean, so I got opportunity to, as it were, dirty my hands in all those fields. And then I began to manage. But after a while, I was director for research for 12 years in the Ghana Health Service. And the next level is the Director General of the Health Service. So there are 8 directors under the Director General. The Director General is more of a political appointment, and I didn't think I wanted to go in that direction. I thought I wanted to be independent-minded and say it as it is, stick to the science and communicate appropriately. So after a while, I decided that, well, maybe it's time to move into full-time academia. I think I must also say that at the time that I was director for research for 12 years, maybe 8 out of those 12 years, I had an adjunct position at the University of Ghana. So it wasn't new. I was doing teaching in the School of Public Health, mainly epidemiology and disease control. I was actually coordinating many of the courses there. So I had my foot in there already. So when I felt that I'd had enough of the Ghana Health Service, I decided to move into the university and be a full-time academic.
And so maybe just one step further to another pivot. When you were working in the rural areas, the rural hospital, obviously you saw a lot of need, but also, as you said, lots of satisfaction. So when you think about the work you saw, how do you think that affected or informed as you went forward, first with the Ghana Health Service in your academic career? Is it really, do you find yourself still grounded by the patients and people and issues that you saw there? Or how do you think about a lot of people here are probably thinking about different kinds of careers, clinical-oriented careers versus sort of policy or research careers. And I guess I'd love to, since you've done it all, a little bit of your reflection about all.
Yeah, I think I was probably privileged to have had all those experiences. At least within the system in Ghana, you get exposed to many of such areas. But you see, you really get, unless you are not human, you really get grounded when you get to the district hospital and you see the reality and challenges of health on the ground. It is very touching, and if you're not careful, you become very emotional about it as well. But beyond the emotions, what can you do? If you are in a district, I remember when I got to Navrongo, I worked in Navrongo for 7 years. When I got to Navrongo, at that time there was the electricity supply to the town was by a generator. So we had power from 6 p.m., that is when at dusk, or is it, yeah, at dusk, yeah, till about 10 p.m., because the generator needs to be filled with diesel. And the authorities did not have the resources to fill the generator with diesel 24/7. So they chose the critical period from 6 to 10. And at 11 p.m., you get a call, there is an emergency, a case of obstructed labor, you need to do a cesarean section, and what do? You can't say there is no electricity, so you will not do the necessary interventions. So we had lamps, chargeable lamps that we worked with. And it makes you see a completely different aspect of life. And when you go back in the morning and see mother and baby recovering and everybody is fine, you just get a sense of satisfaction. Yeah. So, but the issue is that it's not everybody who wants to go and work in that area. So there are some infrastructure challenges.
Yeah.
Of course, now the situation has improved. There is the national grid in that place. I go there now and I see my colleagues sleeping in air-conditioned rooms because there is electricity. And I look back to 1990 when I went there. It was a completely different thing. So things are changing, things are improving, but there is still a basic infrastructure deficit compared to what you have in the Western world. Yeah. So those are the critical issues which one has to engage. And I know that pretty soon many of you would be taking your rural postings into some countries.
That you were going exactly where I was going to go. Please, keep going.
I think your expectations should be modest. It's well, in the first place, many of your predecessors have been there. They've enjoyed it and they've learned a lot. So, yes, it might be a difficult environment compared to what you have here, but you are pretty safe. You may not get the luxuries of Washington or California or wherever, but it's decent. You will get by. And I think you should use this as an opportunity to learn. Occasionally, one or two people arrive with the mentality of being more knowledgeable. But within a very short time, you get to know that you are not as knowledgeable as you think you are. You should see this as an opportunity to learn because there is a lot that you could learn within the, I think some of you used to come for 10 weeks and others for shorter periods. But whatever period it is that you are going to spend in Ghana or Tanzania or wherever, see it as an opportunity to learn. Engage with the health system. There are people within the health system who may not be very, very senior, but they have a lot of experience that you can learn from. I mean, as a doctor, I learned a lot from the nurses that I worked with, the field technicians that I worked with. I mean, when you talk about the cold chain for immunization, I mean, the field technician knows as he can rattle and tell you what he has to do in his sleep. He knows everything. I mean, and he's done it so often and that he knows it. It's part of his being. I mean, so you leverage that experience and try and ensure that you don't go play boss. I mean, you don't be bossy. You have a lot to learn if you avail yourself to the opportunities. Yeah.
Exactly. You anticipated my question. So let me maybe step a little bit farther back in the sense, in addition to all your work at the Ghana Health Services with the university, you've also had quite a bit of experience in the global space with WHO, with the World Bank. And the question, I guess one thought is, we are all studying here, working at a North American university in the United States, the wealthiest country in the world. I guess I'd just be interested in your reflections over the years of working with international organizations and working with donor countries. I wonder if some of the same advice you gave our students might be useful for donor countries and international organizations, but just a little bit of your reflection on, from the standpoint of a leader in Ghana, how should the West, broadly stated, or at least the donor countries and international organizations, what lessons would you give or better ways for engagement with low and middle income countries? Because you've seen this both at the Geneva level and in Accra and in rural Ghana.
Yeah, okay. So again, my exposure to these organizations have been primarily advisory or consulting. So the World Health Organization sets up a committee on neglected tropical diseases. I'm invited to chair the panel. I chair it for 2 years, and then they rotate me off, and another person goes in there. When you are an outsider, I think it's a different ballgame. You are able to speak your mind and let the secretariat, that is the people who work in the organization, really appreciate what the issues are. Sometimes I realize that people who work in the institution appear gagged because they are unable to say things that they really want to say. But if you go in as an external person, as an advisor, that is a completely different ballgame. But it also enriches the space for the decision making. And I guess maybe on the scale of 1 to 10, about 8 out of 10 of the advice that we provide is taken because they see it as something good to do. Maybe the other two, in as much as they may want to do it, their systems and their policy processes does not allow them to happen. But I think that over the years, many of the international organizations who work with us in developing countries have learned a lot on how to work with us. It's similar to the advice that I was given that don't go thinking that you know it all. So if the World Bank is funding some aspect of our national insurance scheme, there are people in Ghana who have worked almost all their life on the national health insurance scheme in terms of its design and its implementation processes and things like that. So if you come from the World Bank and because you are holding the check, you think you know it all, you learn very quickly that it's not as you think it is. Normally, it's the new officers who make such mistakes, but those who have moved from one country to the other, right, by the time they come, they are grounded, right, and they learn to take advice. And we work together as a team to ensure that we deliver the product that is required. I mean, I remember on one occasion there was something about I've forgotten which organization it was that was funding part of our national health insurance program, and they said their money does not go into infrastructure. I said, fine, your money doesn't go into infrastructure. That is your policy. But this is the health post or the health center that you're supposed to deliver the service at. Look at it. Do you think that the people would come into this structure for healthcare delivery. So you need to find an innovative way of not funding infrastructure on paper, but to get things done. At the end of the day, we think through the processes and we are able to come up with something that will not make his bosses in Washington crack the whip on him. So you do some refurbishment here and there, and at the end of the day, you are able to get your program going. So you need to be flexible, reason with the team that is in country, because they have the on-the-ground experience that you do not have.
That should be required lesson for all development officers.
Yeah.
So I'll ask one more question. So then just kind of cue to the group, but I'm going to turn it over to you guys. But the other thing that's sort of been a theme of your career is neglected tropical diseases and research. So I thought maybe you just give us a few minutes about what your research portfolio is today and so where do you, this is an area of work that's by its very definition has not gotten the attention it deserves. Some diseases within that category have gotten some more attention in the last 20 years, certainly more than the years previous. I guess your thought about, so when you look at the whole, I mean, because you edited a book on the whole range of diseases, just your thoughts on research in this space, what's needed, and where should we go from here? And then I'll open it up to the students.
Yeah, I think when I got into NTDs, that's neglected tropical diseases, maybe 25, 26 years ago, it was portrayed as the diseases with no hope or whatsoever. But through research and the dedication of some key scientists, we've managed to make some inroads. And once you have proven interventions that work, then you are able to lobby and get the international community on your side. And there were major clinical trials that showed that something could be done about many of these diseases. And through some advocacy processes, we decided to, instead of going with the names of the various diseases, which are usually a mouthful, lymphatic filariasis, onchocerciasis, schistosomiasis, trypanosomiasis, leishmaniasis. It's all, So we decided to brand it as NTDs, neglected tropical diseases. So if you go to the WHO website, you see 17 diseases that they put in that brand. USAID, I think, has about 19 or so. But the good thing is that the NTD brand has sold. And as a result of that, we've been able to mobilize some resources to do a lot of interventions. But there's still a lot of work that has to be done. One, for the proven interventions, we are not able to deliver these interventions to all the populations that need them. So if you take the 5 diseases that were packaged together, soil-transmitted helminths, lymphatic filariasis, onchocerciasis, schistosomiasis, and I think trachoma. These were packaged together as diseases that one could use mass drug administration to intervene. And through advocacy, we managed to get the big pharma donate the drugs that are required. So Merck decided to donate ivermectin. GSK decided to donate albendazole. Pfizer, I think, donated for the trachoma drug, tetracycline or no. Well, I'll find out and let you know. Pfizer donated something for the trachoma. And then we had some donations also for the schistosomiasis. So now what you need is the resources to go and deliver these interventions on an annual basis in some communities for maybe 5-6 years to be able to control these diseases. Unfortunately, the resources for the implementation has not been forthcoming. And that is where the challenge is. And for those of you who are biologically oriented, you get to know that when you start these interventions and you bring the parasite prevalence from, let's say, 35% in the community to about 5%, you achieve a lot of reduction in parasite density. But if you are unable to continue to the lowest level, which would, as it were, interrupt transmission, and you leave it for a year or two, the rebound effect can be disastrous. So resources for interventions are essential and critical. But you see, the problem is that many of these diseases do not kill on their own. So they don't attract the glamour of malaria, HIV, tuberculosis. It's as if these are the only diseases in the world. Every donor agency is funding malaria, TB, and HIV/AIDS. I mean, I'm not saying it's not important to fund those. Yes, it is important, but look at the whole spectrum. So there is a lot of work to be done in this area, and we also need further research to refine our tools. So we should not leave the research aspect as well, thinking that the goal has been achieved. We need to invest in a lot more research to be able to bring the battle to a successful end. Yeah.
I told you this would be a terrific evening. I think the bridge between research and practice, between science and resources to implement, these are the enduring challenges of global health. So I'm going to open this up. Do I have any questions from? Now, we usually have a couple people assigned. I usually have a couple ringers, but because we didn't have it, so I'm going to need a couple. Somebody's going to get started, and I know how this goes. So who would like to start? Gia, thank you.
Yeah, so I'm just really curious to learn more.
Oh, I'm sorry. Yes, please.
Yeah.
Thank you.
I'm just really curious to learn a little bit more about NTDs. Like, what are the biggest, like, I guess in your case in Ghana, like, what are the biggest political challenges that come with having these diseases that, like, people higher up don't care about or, like, isn't internationally visible?
It's two issues. One, as I mentioned, these diseases do not kill on their own. And mortality is a very important thing when it comes to attracting the necessary attention. Diseases with low mortality rates tend to be neglected. Take mental health, for instance. Mental health on its own has very low mortality, extremely low mortality. And for that reason, it also doesn't receive the necessary attention that it deserves. Politicians, as you would know, always want to be re-elected. So the things that will make them re-elected is what they do. The other issue is that the pie is not big enough. The per capita expenditure on health in Ghana is currently around $80 to $90, which is extremely low compared to maybe $5,000 in some of the developed countries. So government has, let's say, $100 to spend on each person's health. How do you prioritize the use of that $100? And more often than not, the interventions that receive the attention are childhood immunizations. So government would normally want to make sure that that is usually covered. Otherwise, you lose your next election. But even that, we had some challenges recently in Ghana as a result of COVID, where there was a lot of challenges with the economy. We defaulted in our payment of vaccines, and for a couple of months, there were some vaccines that were not available. That is another story. But the issue is that governments would normally want to do what will appeal to the people. And secondly, the per capita expenditure on health is so low.
Next. Oh, please. Thanks. Thanks, Tom.
Hi, thank you for speaking with us. I have a more career-specific question,
Mhm.
but I know a lot of people, especially in the global health program at Georgetown, are kind of battling this decision of whether they should go into medical school or get a medical degree, or whether they should focus on public health initially, as far as higher education goes. And I know I've considered that question as well. So I was wondering if you could talk a little bit more about getting a medical degree and then getting a degree in public health, and what the value of having both is, and maybe what the value of having one or the other is.
Well, if you can afford it, have both. If you can afford it. I think having both gives you a certain advantage. There are certain opportunities that would be advertised, and you would see that they would say, well, the person must have a medical degree in addition to a public health degree. There are not that many, but there are a few out there. So if you want your horizon to be broadened, I mean, you can go for both if you can. And again, it also helps, if you can, to really decide. I mean, you're a young woman, you just getting your undergraduate degree. I think one should explore and see what works for you. I tell many of my friends that if I had another opportunity, probably I would have gone into computer science rather than medicine. Not because I am disappointed in anything, but along the line I realized that I enjoy computing. But in my time, if you did A levels, and you had to do, for the sciences, you had to do biology, chemistry, physics, and what they call general paper. Or mathematics, chemistry, physics, and general paper. These are the only two options you had in the sciences. It's so narrowing, you know. So you finish your A level, and you're either in, if you did science, engineering, medicine, computer science, it's so limiting. So having the opportunity to explore helps. You are doing the global health program, the bachelor's program. Yes, and if you think that you are more interested in the programmatic side of global health, you can decide to do a master's in global health or a master's in public health, with some emphasis on monitoring and evaluation or programming. So then it means you are gearing towards working with some of the NGOs who work in health. But if you really also want to get involved in the decision making of global health and disease specific issues, then going to medical school also helps. Yeah.
There we go. You pass it over there, okay. Thanks.
Hi, thank you for speaking with us.
Yeah.
So you mentioned a lot about studying abroad, and I know many students here will get a chance to do that, which I think is great. It's a very effective way to gain an understanding of health systems that don't look like ours. But I know that there's probably a lot of representatives working for organizations and countries that have not had like personal experience working in the countries that are affected by NTDs and a lot of the research that you do. And so I was just curious how you and your colleagues would kind of get the urgency of your research, that point across to some of these representatives in order to persuade them to invest in further research.
Yeah. So a good question, and it's advocacy. I mean, you have to tell your story. But the good thing is that these days, most of the development agencies would have a couple of people who would have spent time in developing countries. So if you take USAID, for instance, I mean, you would always find a big number of people who have spent time in developing countries. If you take what do you call them, the big NGOs like Save the Children, I mean, they all have country offices. So there is the opportunity for their headquarters staff to do a rotation in some of these country offices and appreciate what it is that goes on there. But in the event that you come across people who haven't had that opportunity, then it's all an issue of advocacy and letting them know the relevance of these diseases. And also trying to invite them to spend some time, even if they're not going to live in the country like the people in their country offices do, at least a visit. I mean, look, one visit of a week to Nigeria can change your whole perspective to life if you see the right things. So, of course, I know of the kind of visits that sometimes they chaperone you to see only the right things. Kamala Harris is in Ghana.
I know she is.
She's in Ghana. I'm not sure what she's seeing now, but I mean, those ones are well organized for you to see the right things. But if you want to come and do health and development in Ghana, I mean, nobody's going to stop you in seeing what you need to see. You see the top-notch hospitals, and you see the very low-quality hospitals as well. So it's a story of two divides. I mean, if you get into some health facilities in Accra, you think you are in Great Ormond Street in London, or GU Hospital or GW Hospital. Right. Yeah, there are a couple of facilities like that, but that is accessible to only a few people, you know. So the inequalities in the system is something that we need to address.
And as you all know, because I told you, even though I've worked in global health, I never lived or traveled abroad. I never visited, frankly. Maybe I should say, maybe I certainly had never been in Africa before I worked for the State Department. So I'm part of the issue of the kind of person that you had to deal with. And there is no substitute for traveling. And it is true that your travel when you're in a U.S. government job is carefully curated by everyone involved. But there is still a chance to learn. But I guess my pitch to all of you would be, don't do what I did. If you have a chance early in your career to see different countries, different cultures, different communities early on, I would urge you to do that. Again, not everyone has all the same opportunities, but if you do, I would urge you to take Let's see, what, next question? Let's see, anybody else? Oh, here we go.
Hi, thank you for speaking with us. My question is actually really similar to Sylvie's, which is kind of just like, I know that you went to a lot of higher education in your life, so when did you decide that it was the right time in your life to go? And if we make it to senior year, junior year, and we're not sure, do you recommend we just go anyways, or like wait and then decide when it seems like absolutely right, if that ever comes?
Our system was different.
That's right.
Yeah.
You weren't choosing.
You weren't choosing. It was a regimental thing. You have to do O level by a certain age, A level by a certain age. I mean, it was all worked out. So I remember when we finished O level, there was an opportunity with AFS. What does AFS stand for? American Field something. AFS.
AFS, American Field Survey? No.
I
Yes.
think something like that. For opportunity to spend a year in the US with a family, to live here and see what the life looks like here. And I told my father about it, that, oh, there is this opportunity. He looked at me and said, are you going to school? I said, no, I'm not going to school. I'm going to spend a year in the US. He said, sorry, you're not going.
There you go.
Yeah, I mean, so it's kind of regimented in a way. But life here is different. You can decide to take a break and come back later. So I think that has its advantages. So that if you are not too sure, you can spend time pondering on what the next move should be. I think if that opportunity exists, take advantage of it. If you're not sure, don't get into it. Yeah.
Any other questions? So maybe what I'll do is ask you a final one, which is to reflect a little bit on if you knew then what you know now, advising the younger version of you. You know, now that are there areas where you look, Ghana has changed so much over the course of your adult life. Mm-hmm. The health system has changed there. What would you do? I guess really, it's partly looking forward, but also looking a little bit behind. What would we do? What change? Where would you make the biggest changes now? If we're going to try to, from where you sit, reach more people with better care, improve health outcomes, which obviously deals with social determinants, things much wider than the healthcare system. But when you look back, what are the things that you wish you'd known then? And looking ahead, where do you think we need to go? Because Ghana is truly a leader in the national health insurance system in terms of health outcomes, but obviously still, much like our own country, has some really big challenges ahead. So I guess a little bit of looking back and looking ahead for us.
Yeah. I think what I'm beginning to see in Ghana now is, yes, things have improved. Indices have improved generally. Almost all our health indices have improved significantly. But my worry now is there seem to be some populations that are not being carried along. So there are some outliers who tend to be forgotten when the averages are done. So you see immunization coverage of about 80%, and you are very happy because when you have immunization coverage of 80%, you are good to go. But there are communities where it is much, much lower. So there are some vulnerable populations which we need to try and ensure that we reach and make healthcare equitable. I'm worried about equity in our delivery of services. The bigger cities tend to have everything, and they get a lot more investments, and this is affecting a lot of migration from the rural communities into the urban communities. So now if you go to cities like Accra, you find a lot of street children. A lot of street children. At almost every traffic intersection, you see them selling, all kinds of things. From gum to candies to whatever they get. They are just to make a living, because the infrastructure in their native villages or towns are not good enough. And they want to make a living, so they've come to the city, but they don't have anywhere to stay, and they don't have anyone to take care of them. It's a challenge. This is not the first time it's been noticed. It's been on the drawing board. Some solutions have been tried, but they haven't worked. So it's still an issue that we need a solution to. And it is pretty sad. Sometimes you go to some of the markets at night. These people sleep rough. So it's an issue that we need to address. So if we're able to, of course, you cannot solve all the problems. The U.S. hasn't solved.
I was going to
all
say,
these problems.
every problem you've described is present here in the U.S.
Yes.
But it is a question of justice, right, and equity.
Yeah. But how do we do it? How do we do it? I don't know. I don't have a solution. But many people think, and probably rightly so, that this is the source of violent crimes in most of Africa and probably beyond. Because if you have a 12-year-old boy migrating to Accra and he lives on the street for 5-6 years, by the time he's 16, getting on to 17, he has picked up so many bad habits. And if he continues on the street, it's a tough life. And you don't know what the next thing is going to be. So, and these people, their health needs tend to be maybe ignored might be a strong word, but we don't factor these in the planning of our health services. Immunization coverage in the peri-urban slums is extremely low. So you may have good immunization coverage, but if you go to the peri-urban slum and you do your coverage assessments, they are very low, because the I don't know whether I should refer to them as mothers, but they are mothers, but they are children. Right. 16-year-olds, 17-year-olds who have given birth, and they are head porters, so they carry stuff in the markets. She needs to go out there and work to earn a daily living. At the time that she is in the market carrying goods to earn money, that is the time the health team have come to do the immunizations. So you find out that their children are not immunized, are not immunized, and it is an issue that we need to try and find a solution to. Some suggestions have been put forth, but they haven't really worked.
Any final word? Because I think you've left us with the justice issues in health, reaching communities that are left behind
Yeah.
and are ignored. I mean, that's the story of the United States, the wealthiest country in the history of the world. But any final words before?
I think you have a very great future ahead of you. Being in Georgetown and being in the programs that you are, I know I'm very familiar with the undergraduate program in global health because we've received many of them in Ghana. I'm in various parts of Ghana, and we've received a lot of very bright students who have gone on to do great things. So the future is good for you. Take advantage of it. Learn as much as you can. This is the time for you to gather experience. And every experience I believe, is worth it. So just go out there, do as much as you can, enjoy it, but do as much as you can. And in the multitude of the things that you do, you find a niche that you may fall in love with, and then decide to follow your heart and go in there and excel in those areas. One of the things I used to tell my graduating students every year is that you should be so good that no one will ignore you. I mean, when you are in the field and there are 100 of you doing the same thing, you should be so good that nobody can ignore you. Your peers will not ignore you. Your supervisors will not ignore you. And the sky will be the limit.
Johnny, that's a perfect way to end. I wish everyone would join me in a round of applause. So thank you so much. This was wonderful.
Thank you.
So, thank you for doing this. So we're back on our regular schedule, but thanks everybody. This was terrific.